Welcome to our session today. My name is Jane Houston and I'm the Clinical Director of Midwifery and Women's Health at Frontier Nursing University. It gives me great pleasure to introduce my colleague, Dr. Anne Judge, DNP, WHNP. Anne graduated from Stanford University in 2001 with a degree in human biology. She obtained her nursing degree from the University of Washington in 2005, including an honours research project. She graduated with distinction from both schools and was a member of Phi Beta Kappa and Sigma Theta Tau. She began as a labour and delivery nurse before personal experiences with infertility led her to reproductive medicine. She has worked for 10 years at Washington's largest fertility clinic, Seattle Reproductive Medicine. In 2017, she completed her Doctorate of Nursing Practice program at Frontier Nursing University as a women's health nurse practitioner. It gives me great pleasure to welcome Dr. Judge to our presentation today. Thank you.
Thank you so much, Dr. Houston, and I'm really excited to be speaking to Frontier. As you mentioned, I have not been gone that recently. I just finished in June with my DNP project, which was actually on standardizing obesity management in my fertility clinic, and I'm really excited to get to talk to you today about what I learned with more of a general reproduction focus. So not so much on women who are trying to get pregnant, but also how we have these conversations about weight and making changes for women once they are pregnant, since I know that might be a little more relevant to a lot of you listening. My objectives for today is that by the end of this talk, I hope you can reference some current research on obesity and reproduction. I also would like you to be able to discuss how weight bias influences healthcare, because that was one of the big things I learned with my project. I want us to talk about weight, but I don't want to make a problem even worse by having a lot of bias. And to do that, I hope that you'll be able to list some principles of motivational interviewing and talk about how it can work to encourage lifestyle change. So first, I want to talk about some definitions, and we have to start by talking about BMI, or body mass index. And I know BMI is not perfect, but it really is the best, most consistent and understood screening tool that we have. Body mass is calculated by taking a patient's weight in kilograms and dividing by the square of their height in meters. And I know most of us have an EMR that does this for us. And the reason that we use it is it's not a direct measure of body fat, but it has been found to be moderately correlated with more complex measurements like skin fold testing or underwater weighing, and it's been pretty strongly correlated with the metabolic and disease outcomes of excess body fat, which is ultimately what we care about anyway. A lot of patients, if you talk about BMI, will bring up that fact that it's not a direct measurement. And from that, if someone has a lot of body mass, a lot of muscle mass, because of exercising, that will put them into a higher BMI category. But the patients that I'm talking about today are not the people that are a bodybuilder and therefore their BMI is 26 instead of 23. I'm really talking about the patients that meet the medical definition of obesity, which is a BMI above 30. And I think it's also important to remember that if we're going to further subdivide, we need to use the official class designations. So class 1 obesity is BMI between 30 and 34.9. If you go up to 39.9, you're now in class 2 obesity, and above 40 is class 3 obesity. And these are the terms that we should use. The term morbid obesity is really not something that we should say. We wouldn't say that someone is morbidly hypertensive because they have a high blood pressure. We divide that into classes, and we can divide obesity into classes as well in a less judgmental manner. And the prevalence of obesity is something that has been on the upward trend for quite some time. These are the stats from the CDC. And you can see that there is a variation demographically across the US. I'm up here in Washington, and I'll show you a little bit more from my state later. But all regions are now at least above a 20% obesity rate, with a lot of states in the South with a rate above 35%. And if you further subdivide into females, you see we now have even more states in that above 30% category. And multiple articles mention that in specific communities, you have obesity rates well above 50%. I'd encourage you to go to the website for the March of Dimes, because you can further break this down into women of childbearing age. Again, I'm from Washington, so we're a little bit lower than some of the other places in the US, but you can still see our rate being close to the 25%. And you can also see how we have this upward trend over time. And I'd encourage each of you to go and see what the rates are for your specific community. I think you can even go as far down as county. And the reason we want to talk about this is because as obesity increases, we see both a decrease in pregnancy rates, which is what I spend most of my time talking about, but also an increase in obstetric complications, which is what probably a lot of you are a little bit more concerned about. I want to first start with the decreased pregnancy rates, and a lot of this information comes from a bulletin and provider guide from the American Society for Reproductive Medicine. It's a great article if any of you are interested in the fertility aspect of it. It has a lot of information about all the studies, but big picture, we know that obese women in general have a higher chance of having fertility challenges. If you look at two women and one is normal weight and one is obese and they both stop contraception, the odds are about 81.4% that normal weight women will conceive in that first year after contraception, and they're only 66.4% for women who are obese. A lot of this is because of ovulatory dysfunction. The rate of having ovulatory difficulty is about 3 times higher for women that are obese. But you do see both a difficulty getting women into a good ovulation pattern if they have an elevated BMI, and a decreased chance of success even in women who are ovulatory. In fact, you even see a decreased chance of success from assisted technologies like in vitro technologies. ASRM reviews a meta-analysis of 33 IVF studies. This includes over 47,000 women, and they did find a statistically significant reduction in both pregnancy rates, about 10% lower, and live birth rates, about 16% lower. And that's in this really large study. If you look at smaller specific studies that stratify by BMI levels, you see even more dramatic reductions, especially in BMIs that are above 40 or class 3 obesity. And of course, when women do become pregnant, you have that higher rate of obstetric complications pretty much across the board, anything that you can think of. You have higher rates of miscarriage, higher rates of hypertension, higher rates of gestational diabetes, preeclampsia, stillbirth, the need for a cesarean section or an instrumental birth, risks like complications of shoulder dystocia, and you can have infants that are either small or large for gestational age. So this is why we want to talk about this topic. It's something that we know has a lot of impact, but what do we do with this information and how can we share it with patients? And this is something that we really are not doing a very good job on. One example is to think about gestational weight gain. They found in one study that although 95% of providers report they do give advice on gestational weight gain at their prenatal visits, in that same study, same women population, only 29% of women recalled actually getting advice on gestational weight gain. And the advice that we give also unfortunately seems to vary by BMI. Another study found that although 71% of normal weight women in this study said, oh yeah, I think at my prenatal appointment they did tell me about my weight gain, that percentage was lower for obese women. Only 55% said they were given advice. And this may be related to how they hear the advice, or it may be that providers are more uncomfortable discussing it. Even a little bit more concerning in the study, of the 55% of obese women that did recall getting advice on gestational weight gain, 39% of them recalled advice that was higher than the Institute of Medicine guidelines. So we're not having conversations about weight all that effectively, either preconception conversations or conversations about gestational weight gain. And I think that's too bad because we do have a lot of good information that these conversations can make a difference. An early Cochrane review in 2012 found when they were trying to study excessive gestational weight gain that they had insufficient evidence to recommend anything. But luckily in 2015, now that they've looked at 65 randomized controlled trials, so a total of over 11,000 women, they now state in this Cochrane advice that there is high quality evidence that women who make changes in diet, who exercise, are both equally effective in preventing gestational weight gain. And I really think as we try and have a conversation that equally effective is the key. People can make diet changes, people can increase exercise, they can do both. Any combination of those things will work. And as midwives, we're all about shared decision making. So it's not our job to tell women what to do. Our job is to try and have a conversation about the information that we have and let each individual woman decide if and then how she might make some sort of lifestyle change. You don't have to do everything, but at least doing something can help. And we know that obesity is an increasingly common risk for the women we serve and that we could be doing a better job talking about it. But as we think about how to talk about it, I want us to also be aware of the issue of weight bias. Another great article that's cited in multiple studies and is highly worth a read is a review article by Puhl and Hurler. Now, this was in 2009. It's a systematic review of over 200 articles. They looked at everything from 2000 to 2008. So I'm keeping my fingers crossed that they may be preparing an updated one for this decade. But they find just across the board a lot of good evidence of weight bias in all aspects of life. I'm just pulling a couple of the ones that relate specifically to healthcare. And here you see in one survey of primary care physicians, over 50% admitted that they have often a view of obese patients as being awkward, unattractive, ugly, or non-compliant. And again, these are things you're admitting on self-report surveys. And you see that same self-reported stigma from women, that 2,449 women reported 69% said they had experienced stigma about their weight at least once, with 52% saying more than once. And this one I think is interesting. On that same survey, picking from a list, out of 20 possible sources of weight stigma, physicians were selected as the most common source that women reported they felt stigma about their weight. Now, we also have in this article some experimental data, which is consistent with self-report findings that weight bias is an issue. Again, I just picked a couple of the ones that to me seemed most interesting. This was a survey of 122 primary care physicians who were given 6 patient scenarios to kind of say what their impression was, how they would approach care. And the scenarios were actually identical, except for the BMI being different. And they found a linear relationship. As the BMI went up, physicians judged the patients as being in less health and having less discipline and being less likely to comply with recommendations. And Puhl and Hurler make a really good point that we know from science that having sustainable, significant weight loss is very difficult. And this is frustrating. It's frustrating for patients, but it's also frustrating for providers because we like to fix problems. And so when we feel like we can't fix a problem like obesity, this frustration can often translate into being biased and having negative interactions with patients. We kind of blame the patient for our recommended treatment of not working, that I said they should exercise and they haven't fixed their problem, instead of really thinking about all the factors that go into the current obesogenic environment that we live in. This is another interesting study because it was looking at students that are studying to be dietitians. So these are people that are likely going to have a career talking about health and weight. And they were also given patient profiles of patients with obesity. And they rated that patients, when the BMI was higher, they said they had a worse diet, they had a less healthy lifestyle. Again, they rated they would be less likely to comply with recommendations, with advice that they might give about diet. But the profiles they were looking at actually had identical diet and lifestyle information. The only thing that differed was what was the reported BMI level. And so we see that weight bias really is an issue. One more study that I like, just because it's more recent and because it's specific to prenatal care, and especially how we talk about weight. It took 22 prenatal care providers, and they made audio recordings of their interactions with 117 patients and then coded them. And what they found was that when women were overweight or obese, providers tended to ask fewer lifestyle questions. They gave less lifestyle information. They used fewer approval and concern statements, and they also used fewer self-disclosure statements. And this change in interaction style means you're not only giving a lower quality of information and care, since you're not really asking questions or giving the same information, but by using fewer approval statements and fewer self-disclosures, you're not having that same back and forth that's really important to build that relationship and sense of trust, especially for something like prenatal care, where you're hoping to have a long-term relationship and really know and support each other. And this stigma does impact patient care. They found that patients with obesity have lower rates of preventative care visits, and that's even after you control for associated factors that can contribute to reduced care, such as having lower income levels, education levels, or health insurance. And multiple studies showing that women specifically avoid gynecologic care. You see lower rates of cervical and breast cancer screenings through PAPs or mammography for women with obesity. And that's especially concerning because obesity places them at increased rates of having some of these certain gynecological concerns. And when women are asked why they avoid care, you see that as the BMI level goes up, a lot of women cite not only concerns with how they're going to interact with their provider, but embarrassment at the thought of being weighed or feeling like the gowns and equipment are not going to be suitable for them. So, as much as I think that we need to have a conversation about obesity with women, I think it's equally important to really think about how to have that conversation. And I would suggest really two or three main goals. First, to really be aware of weight bias, both at a personal level and a societal level. I'm going to show you a lot of toolkits, and they're listed in my reference list, and I would really encourage you to look at them. One in specific, the Yale Red Toolkit, has a self-assessment test, a few of them actually, that can kind of assess your own awareness and weight bias. And I found it really eye-opening after months to years of even researching this topic for my DMP. I still found that I had bias as a pretty significant issue. And when you're sitting down to talk with a patient, remember that the odds are very high your patient has had a provider bring up their weight before, and it may not have been in the most sensitive manner. In fact, some patients report that they spend a lot of the early visit just kind of waiting for somebody to bring up their weight. So you want to think about each patient and each clinical scenario as being different. Really see them as an individual, and your goal should be to let whatever their goals and questions are for the visit guide your conversation. And the conversation that you have should really focus on lifestyle change and improving health rather than weight loss, or I guess if we're talking about pregnancy, not just about maintaining an appropriate gestational weight gain. It's not just about the numbers, it's about what they're actually doing in their life and their health. So how can we have this great individualized discussion about healthy lifestyles? It is clearly a natural fit to utilize the techniques of motivational interviewing. In fact, MI is what's endorsed by ACOG in their toolkit as the preferred way to discuss behavior change, including weight with patients. And it's not a new concept. It was first introduced back in 1983 with the first book published in 1991. And a lot of you, if you're at Frontier, have used this book in 2008, which focuses specifically on the use of motivational interviewing in healthcare. And this is a great book. It's not a textbook. It's a really accessible, easy, quick read. Because it's from 2008, you can get used copies online for less than $20. And what's great about it is it not only goes into the background and philosophy of MI, but has a lot of sample vignettes and patient conversations. And I found it really useful. I'm not going to be able to give everybody complete comfort with MI from this talk, but what I hope to do is at least pique your interest enough to look at some of the resources that I'm listing. But the main principles of MI is such a good fit with midwifery because it's all about giving the power back to women that we're trying to help. Remembering that we may be their healthcare provider, but they are still the expert on their own life and their own circumstances. And they use the acronym RULE to think of what motivational interviewing is about. The first one is often for me the hardest, and that's resisting the tendency to correct patients. I think it's natural. We've learned all this information. We want to share it. We want to be directive in telling people what we think we could do. But if you find in conversations that you're the one making suggestions, you're really in the wrong role. You're taking all the good lines. If you tell them you should go for a walk at lunch, they're going to come back to voice the counter tendency. Oh, I have too much work. I always eat at my desk. So you really want to instead practice being a little bit more quiet and seeing if they'll come up with the suggestions, because they're going to be much more likely to actually make a change if it feels like it was their idea and if it's something that they have thought of and could therefore really work into their life. So if you reflect back hesitations, they're going to be a lot more likely to try and come up with a solution than if you're providing it and they're just going to argue why it won't work. And to do that, you really need to understand the patient. You need to be genuinely interested in their perspective. Ask them why they might want to make a change. Ask them how they might do it instead of telling somebody. You really need to understand what each individual woman's goals are and whether they even have any interest in making lifestyle changes. You also want to listen. It's interesting in the studies on MI, they find that when you listen to patients, they actually report that you spent more time with them than you did, versus when the conversation is mostly you speaking and providing information, they rate that they had less time for the visit. Patients tend to underestimate the time you spend speaking at them. And if it's really more of a back and forth conversation, they feel a lot more heard and will feel like you spent more time even if you didn't. So I know the concern sometimes is if I ask these open-ended statements, what if I can't get on to my next patient? But you can have an effective guided MI conversation without having to go over in time once you get a little bit better at it. And finally, empower. You really want to support the woman's hope and optimism that they can be successful in whatever changes they try to make. Again, remembering that they're the one that's going to go know best how they can incorporate any kind of changes into their life. And fortunately for all of us, both obesity and motivational interviewing are very timely right now, and there are some great toolkits. So you don't have to start from scratch. This is one that I really like. It's from STOP, which is the Strategy to Overcome and Prevent Obesity Alliance, and it's all about how to discuss obesity and health with patients. Now, it is a little bit more primary care focused, but it's a great article because it also summarizes a lot of the current obesity research and has examples for sample conversations. So if reading a book is still too time consuming, this is a nice, easily free accessible toolkit online. And again, the website is on my reference list, and it gives you a lot of communication strategies to use as well as real life examples. I mentioned before the Rudd Center. They have a few different toolkits, both related to MI and the weight bias one. And ACOG also has a toolkit that provides some links to sample scripting for MI conversations that are more specific to prenatal care. And it also even has a PDF on how to code visits that relate to obesity. So I'd check out both of those as well. And this is just an example of the kinds of questions that we're talking about using if you're going to use motivational interviewing. And if you look at the emphasis, this is really the key point, that what you're trying to do is have the focus on the woman. You know, how do you feel? What is your current weight and how is it affecting your life? What kinds of things have worked for you in the past? Really have them think about whether they are even motivated to have this conversation, because that's really the first part of this. Not everybody's going to be willing or receptive, and that's fine. You maybe just plant that seed and see if at a future visit it's a better fit. This is a toolkit from the Oregon Health Authority that uses just a brief intervention. It breaks MI down into 4 steps, and this is kind of what I modeled my DMP project off of. It doesn't have to be a big deal. You start by just asking permission. Can we take a few minutes to discuss your health and your weight? And if they say no, you're done. You know, it's only something that's going to work if both of you are interested in having that conversation. But if the patient does agree, then you share the BMI and ask if they have questions. Again, you want to let whatever their questions or concerns are about it guide your conversation. And they give you a few sample questions to get that dialogue going. And if they are interested in making a change, you assess how ready they are. If they're just in that thinking about it stage, you just go back and forth about what might make you more ready to think about changing your diet. Just, again, you're trying to build for future conversations. You're not going to accomplish everything in one visit. Versus if they list that they are really ready, then you try and make a specific plan for how they're going to do those changes. And then you close by just summarizing their ideas and perspectives and what you talked about and what you're going to do next. And I know that trying something that's a little different can feel awkward at first, but I want to remind everybody that we have a lot of awkward conversations. We talk about people's sexual practices and vaginal discharge and all kinds of things that felt a little bit awkward the first time that we did them. But the more it becomes a part of your routine, the more natural it feels, and the more comfortable you are, the more comfortable the woman will be having that conversation back with you. So I hope this talk has helped you understand that although we have a lot of data showing the impact of obesity to reproduction, we also have learned that there's not a quick fix. And because of that frustration, weight bias is still a really real issue in healthcare. And I think that only by being aware of our own biases and actively working to change them are we going to be able to change ourselves as well as change this culture of healthcare. But there are a lot of resources out there that can help. And again, I'm going to highlight a few of them on the reference list. And I encourage you to think about printing out that sample conversation slide. Just read it through a few times, try it the next time you have something come up and see how it goes. And then you modify and adjust it as needed. Remember that MI is all about recognizing the woman as being the one in control, because she is really the only one that's going to determine whether any kind of change is sustainable. I do think we need to talk about obesity, but not in a way that pretends that we are the one that has all the answers. You want to see each woman as the individual, the expert in her own life and circumstances, and the only one that's actually going to determine if she makes a change. So in my reference list, again, you can see the toolkit for ACOG, the March of Dimes website where you can search for your own state and county. This is the website for Oregon Health Authority Toolkit. And again, it's got a lot of good resources on it, as well as the STOP one here and the Rudd Center for Food Policy and Obesity. And this is the weight bias toolkit. But if you go there and poke around, again, they've got a lot of good resources as well as some articles. And my email is also here at the end. So if you have any questions, this is a topic that I'm really interested in, and I'm glad to hear from any of you. And I appreciate you taking the time to watch today. Thank you.